So I think we have about 20 minutes for questions and answers, and I would just ask that when you ask a question, if you could identify yourself and your institutional affiliation, it will be helpful. Wendy.
Wendy Demark, University of Alabama at Birmingham. And the one thing that I heard kind of throughout the talks here is, can we get the magnitude of effect with interventions, and particularly with those that are delivered via distance medicine. So the one thing that I just want to kind of put the point out here, cancer's complex. Much more complex than heart disease, although some people might correct me that are in that area. Much more complex than diabetes. And when you exercise people and when you have them lose weight, there are a whole symphony of different effects that are created. So if we look at insulin, yes, that's good, but at the same time, what's happening to the immune system? You know, if we do pursue weight loss really rapidly, we know it bottoms out the immune system. So how do these things act in synchrony? And so, and I kind of think that we have to open our brains to think that there may not be a linear response going on here. There might actually be a J-shaped curve, which Pam has reported on a number of her papers. So, you know, is there a sweet spot? And I think we have to just avail ourselves to the fact that there might be. And I think Carrie mentioned that with the exercise trials, seeing that, you know, there doesn't seem to be an effect of too much exercise. But I think we have to be cognizant of the fact that when we do these trials, we have to be looking for that. We just completed a trial where which causes some concern on my part, where the men that lost more weight had higher proliferation rates than those that lost modest amount of weight. So why is that? And I think it's very, very complex, and I put that out there.
I think that's absolutely true, and that's one of the reasons why it is so important in these big studies that we're collecting the material so that we can look at that, because I don't think any of us know what these trials will show. We are all very hopeful that in everybody there'll be a great effect and that there will be something very simple that we can point to and say, oh, it's because of that. The reality will probably be much more complex. But the thing with being able to do larger trials with these biospecimens is that we'll be able to look at this in more detail than we've ever been able to before. I agree with you completely that the data that are out there now from small studies, from preclinical studies, sometimes are confusing. And the reality is we're at the point where we're finally going to have some data from people. It'll probably take us another 10 years to be able to untangle what it shows, but we'll be that much closer to understanding this to be able to prescribe this in a way that we know will help our patients.
So I'll just make a comment as well from a fat perspective. What you said is absolutely true, and fat remodeling is a time-dependent event, and it depends on, undoubtedly, it depends on the magnitude of weight loss and at what point you look. But it is by no means an obvious thing that each and every intervention will yield a beneficial effect, and what timing and what dose or what magnitude of weight loss likely to matter a lot. Not something very simple as one might think.
I think that's ultimately why we need the clinical cancer outcomes. The mechanisms are very complex. They can be going in all sorts of directions, whereas the clinical outcomes of a recurrence or death from cancer are quite clear in terms of the benefit. So relying on the mechanisms and the biomarkers to roll out programs with the assumption that if you change these biomarkers in the right direction, these good clinical outcomes will inevitably follow, I think is probably not the way to go.
And I would agree with that, and I'd go a step further. And, you know, we have some clinical programs for our patients, and many patients embrace them, but some don't. And they feel, many of those women that don't embrace them or don't lose weight or don't become physically active feel guilty, and they're worried that their inability or their decision not to make lifestyle changes will actually lead to a recurrence. And I think we need to pull way, way back from that. We have no evidence right now to say that that is the case. I think we can talk to them about fatigue, about aromatase inhibitor-associated symptoms, but I think we need to be respectful of the women that either won't or don't want to make those changes.
I would also make the point that we heard the term precision medicine used. With the cost of the genome decreasing, or analyzing the genome decreasing by the month, it's predictable that host responses to a given perturbation are going to be highly variable depending upon your genome. And being able to tether DNA collected in samples to response will, I think, be very informative over time. Please.
John Gardner from Pragmatica Corporation. Very impressive enunciation of the ongoing clinical studies. Before coming to this meeting, I looked at the New England Journal of Medicine, and the January 17th issue talks about a review article related to obesity. And the first two considerations related to environment and genetic factors. And I was wondering whether exposure to environmental contaminants or work styles leading to stress would have any connection to results obtained from exercise and loss of weight. In terms of genetic factors, your last statement relating to analyses from DNA samples, could that elucidate some of these considerations about propensity for obesity? I'm a statistician, so not a clinician, and I'm very curious about some of these other factors which may exist in data that could answer some of the questions that relate to the New England Journal review article.
So I think the rapid change in the obesity levels in the population is strong evidence that environmental factors are important. But I think those environmental factors can then affect things like gene methylation, gene expression, so that we may still have an input from genetic factors, and different people with different genetic makeup may respond in different ways to the environmental changes that we're seeing. I think, as several speakers have talked about, this is part of the unraveling that we need to do, and it's one of the reasons why it's critical in the trials that are ongoing that specimens, biospecimens, are collected so that if an effect is seen, we can begin to unravel what was it about the environment, what was it about the intervention, what was it about the patient and the patient's response to the intervention that led to a benefit.
I'll also make a comment, because we're about 2 hours into the meeting and I haven't heard anybody mention the microbiome yet, which is, so it's obligatory in response to your question. But on a serious note, it is highly likely, I would predict, that that will be an important player, and there will be inter-individual variability, and that inter-individual variability may well impact upon response to different interventions, be they weight loss or exercise. And I would also argue that from the standpoint of sample collection, it's much more challenging to do well, and that could prove to be a meaningful omission in some studies, but hard to do.
My name is John Gardner. I'm retired from the National Center for Health Statistics, but that has very little to do with my comment. I'm also a prostate cancer survivor. Most importantly, in the latter stages of my career and continuing into my retirement, I have focused on research integrity with an emphasis on statistical interpretation. And I consider statistics a measure of uncertainties. But we're not measuring uncertainties if we ignore areas of uncertainty. And I keep bringing this up in various venues, and it's always annoying, so I've got to warn you that you may not appreciate what I'm about to say. But on the other hand, I get some positive feedback. I have just been informed I will be made a fellow of the American Association for Advancement of Science on the basis of my work to try to help improve research integrity. So with that, I'm trying to be constructive here, although it may not sound like that. As my experience with fairly early stage cancer treatment was that there were considered to be basically 6 different modes of treatment: 2 types of surgery, radical or robotic, 2 types of radiation, implanted or external beam, cryo, and benign neglect. When I did a search on this, I found, unfortunately it's probably predictable, that what was favored depended on the group that the writer belonged to. So surgeons felt that surgery was always good if it was a feasible approach. Internal medicine people felt that surgery was always the last thing you should ever consider. Anything that you could do with medications would be far superior. Not only that, but what I found with my own doctor was that while he encouraged me to look at all the different approaches and said nothing when I selected cryo, after it turned out the cryo wasn't a solution for me, then he was devastatingly dismissive of me for my ignorance in selecting that, although he had made no recommendation, and there were many alternatives, and there were pros and cons to each one of them. So this tells me that there may be a couple things that I haven't heard this morning. Do the effects of diet and exercise vary with the type of treatment that is used, say, in prostate cancer or perhaps in other cancers? Secondly, is there a room, as there is in most research, for researcher bias? Might researchers evaluating some of these studies that you're talking about favor one type of treatment over another, and therefore be more looking for a positive outcome in the case of a treatment regime that they favor as opposed to one they don't favor? So those are questions in my mind. I hope they're not too disruptive.
No, and I think, certainly there is always uncertainty in research, as you point out. I think a lot of these trials in the early stage patients have tended to enroll patients after they're done with therapy, although the good thing about many of these large trials being conducted through cooperative groups is that we'll have a lot more information about the treatments that patients actually did receive. So we're able to look at that in a different way than has been possible in a lot of the observational data sets. In terms of bias, these are randomized trials. They're enrolling patients through hundreds of different centers across the United States, and they have very prescribed follow-up periods where patients are seen, whether they're in the intervention or control group. So, I think that those are always concerns. These trials are being conducted much more in the way that we conduct trials of new drugs or the surgeries or things that you talked about before. So there's always a possibility of some bias, but I think that with a large trial that's being conducted in a very prescribed way, this is probably the closest thing that we can get to the ability to collect these things cleanly.
Okay, thank you.
One theme in a lot of
Please introduce yourself, name and affiliation.
I'm Darshak Sanghi at Optum Labs. One of the themes I think appears up in clinical medicine regularly is that we have to make decisions based on incomplete information. So I think rather than, one of the takeaways here is that we could say things are complicated, we need to do more studies. Alternatively, we could say the preponderance of evidence suggests it's time to strongly incorporate weight management as part of as part of initial oncologic management, and national guidelines should be reflected in that manner, payers should start to actually strongly incentivize that reduction, and this should start to be reported as a mandatory quality metric. Do you think we're there yet? Or, I mean, it looks like we see substantial enough reductions and the preponderance of evidence is far enough along the line to potentially suggest that. Or do you think we need more studies?
Canadians are heading for the microphones. You know, I think there's a difference between observational data and interventional data. And I think that we have fairly consistent observational data, but as we've just heard, data and researchers can be subject to bias. I mean, we may be looking only at the studies that were positive. We may all have the very same biases in our studies. We may be, you know, measuring healthy person bias in a very detailed way. So I do think we have to focus on the data. And my point earlier was that it's not easy to change lifestyle. And we are the group that wants to. And we deal with patients that want to, but we have to recognize there's a group of patients that find it very burdensome and don't want to be forced to do something they don't want to do. I think that there are enough data for the non-recurrence and survival outcomes to make recommendations for lifestyle interventions based on quality of life, fatigue, aromatase inhibitor associated joint symptoms, and we can get additional data in the very short term for those other outcomes. I think that's where the emphasis needs to be. I remember in the 1980s when David Spiegel had preliminary data from an unplanned secondary analysis of a group support study in metastatic breast cancer that suggested women who participated in those studies would live significantly longer. And that led to all of us recommending our patients be in support groups and women feeling they had to bare their souls in these support groups, whether they were support group people or not. Our group in Canada actually did a randomized trial where we worked with David Spiegel to deliver that intervention. We had a control group that got usual care, we had the intervention group, and we found not only no effect, there was actually a trend towards worse outcomes in women that participated in the support groups. So I think we sometimes know the answer, and sometimes we're right, and I really, truly hope in this area we're right in terms of cancer outcomes, but we don't know that yet. So that's a very strong response, and I'm sure others will not feel as strongly, but I think we need to be as respectful of the lifestyle area as we are of the drug and radiation and surgery area, and we require strong evidence.
I think it's pretty clear from the patients that the recurrence outcomes and death from cancer is their number one concern. Mm-hmm. So we can't sort of lose the forest for the trees and say, well, it'll reduce your fatigue or it'll do these other types of outcomes, not knowing the impact that it has on what patients will call the most important outcome. We know that patients will forego all sorts of quality of life benefits for small improvements in survival. So they are heavily driven by what's going to improve my survival, and I'll endure any sort of toxicities and sort of flip that around and say, here's something with a quality of life benefit, but actually is going to hurt the outcome that's most, I think is a disservice. And, you know, once you roll this out to 15 million cancer survivors, I don't think you can roll it back. You know, this is not one of the drugs where then we put out a recall and say, actually, the effects are not good. So I'd really like to see the data on the recurrence and cancer outcomes, and I think even reassuringly, null findings might be okay. You know, so we at least say, hey, there's no negative impact of this program that improved quality of life, fatigue, symptom management, and had no negative impact on disease-free survival. So even with the weight loss or the exercise trials, that would be somewhat reassuring, because the risk is if we flip it around the other direction and say, wow, we've got some findings opposite to the observational studies, then I think that wouldn't be in the interest of the patients.
So let me be the devil's advocate. Do you think that the risk of adverse impact on cancer outcomes is sufficiently strong that we should not offer lifestyle interventions for the outcomes where we have seen benefits like quality of life?
I just wanted to make one comment following up on what Carrie said, that I think there has been few studies looking at this, but important implications of the role of exercise and weight management on treatment efficacy and adherence. And when we're looking at disease-free survival endpoints, exercise and weight management may help with the quality of life and fatigue, but one of the other mechanisms may be through treatment adherence. We know a number of women choosing not to take AIs because of potential side effects. So if it was the uptake of AIs was in addition to having a personal trainer or access to a gym, and that would help with the adherence to the medication, I think that's an important role for exercise and weight management.
I'll just make one comment as well, because I appreciate your point, and I'll give one example that I found to be relatively sobering, and that was a preclinical study I was involved in where certainly weight loss should have led to a reduction in tumor growth. How could it not? Well, in fact, it didn't. And there were epigenetic changes that were found subsequently that could help to explain the refractoriness of that tumor to a weight loss intervention. Now, would I extrapolate to the human? By no means. But I can't tell you today, for example, if weight loss in an obese individual were to be beneficial, how much weight loss? Over what period of time? So and what level of evidence is going to be needed for it to be reimbursed, for the intervention to be reimbursable from a practical standpoint if one were to clone the idea and try to build it out? Okay, so I don't know what sign that would be.
We're done.
But my laryngeal nerves were just cut bilaterally, and so I think that officially means that this session is brought to a close.